Good afternoon. I'm William Malm, Public Information Officer for Austin Public Health and the moderator for today's news conference. Spanish interpretation is available on ATXN3. To start, we will have opening remarks by Dr. Desmar Walks, Austin Travis County Health Authority, followed by Dr. Kristin Mondy of Dell Medical at the University of Texas at Austin, then Dr. Mike Stefanowicz of Community Care, and we will close with Adrian Stirrup, Director of Austin Public Health. We will then open it up to our poll reporter who will ask questions on behalf of media. Dr. Walks, over to you.
Good afternoon, everyone. We're here today to talk to our community about monkeypox. Monkeypox is a virus that is causing illness in our community and is a growing concern as we have identified more cases over the last few weeks. And we wanted to have a discussion and make the community aware of the situation. This virus is no longer something that we can say is just associated with travel. We now have spread in our community. And so it's important that we understand that how this virus is spread and how we can protect ourselves. The virus is spread when someone is in contact with a person who has monkeypox and they touch the skin of that person where the rash is located, have sex with a person who has monkeypox, shares utensils or beverages with someone who has monkeypox, or has splashing of body fluids in the eyes, mouth, or genitalia, because the virus is in the fluids that I've described, and it's also present in the scabs that form after the blisters from the rash start to dry up. So it's important to clean surfaces after someone has touched those surfaces or sat on clothing or used linens to make sure that you're not putting yourself at risk. And to clean those surfaces, it will be important to wear a mask and gloves and eye protection so that you can keep yourself protected. This disease that is caused by the virus that is causing monkeypox is self-limited. So most people will have illness and rash and have resolution of the illness within 21 days. However, in some people, it can be cause severe illness. And my colleagues who are here with me today will talk to you more about those details. We are currently working with the Department of State Health Services and the CDC to provide testing to people who we suspect have monkeypox. And we are also working with the Department of State Health Services and the CDC to obtain vaccines that are limited at this point in time for use in people who have had close contact with people who have had monkeypox confirmed. We're also working with the CDC to receive medications to treat monkeypox, and that medication is located in the Strategic National Stockpile. So we do have ways of combating this disease for those people who are at risk for severe disease, and those supplies are being set aside for those people who are at risk for severe disease. We currently have 9 confirmed cases of monkeypox in the Travis County area and 8 presumptive cases, which means those people have had that preliminary test that shows that they have non-variola orthopox, and that is then sent for confirmation to the CDC to confirm monkeypox. With that, I will turn this over to my colleague, Dr. Kristin Mondy from UT Dell Medical. She's the Chief of Infectious Diseases. Thank you, Kristin.
Okay, thank you so much, Dr. Walks. Again, I just wanted to reiterate what she said, that for the vast majority of patients, it's really a mild self-limiting disease. Just a little more information. Classically, monkeypox, there's 2 strains. There's a West African strain, which is one that's been circulating in this outbreak, and a Central African strain. This West African strain is the one that's been associated with more milder symptoms, and per the CDC and WHO, generally expected mortality of less than 1%. However, there are populations that can be at higher risk, so there's host factors, and then extent of virus exposure and the nature of complications. And to go into that in a little more detail, for example, we do see from prior studies and CDC guidance that people, for instance, who are immunocompromised, those that might be on chemotherapy or very potent steroids or immune modulators or have very advanced HIV infection can, for example, be at higher risk. Pregnant women, they can be at higher risk, and we know that the disease can pass from the placenta to the fetus. And then also from data, younger children, the CDC typically cites children under 8 can be at higher risk. So those are high risk populations. And then with regard to the extent of virus exposure and nature of complications, so people do need to be careful when managing their own lesions. You could touch a lesion, and then, for example, some cases have cited where you could accidentally inoculate your eye, for instance, rubbing it or putting in a contact lens, and that could lead to a pretty severe infection in your eye. Or if people had multiple skin touching, perhaps in intimate relations, and they ended up getting extensive monkeypox on many parts of their body, including very sensitive areas, not only the eyes, but perhaps mucosal areas, like it could cause, if you got it in the anal area, rectal bleeding, colitis. It can pass through respiratory secretions. So if you got a lot in that way, there's potential for case reports of a pneumonia. And then for some people that have a lot of irritation, scratch their lesions, pick at them, whatever, people could get really severe secondary infections requiring hospitalizations. And so I think it's those kinds of more severe, widespread, or people accidentally auto-inoculate themselves in an aberrant area like your eye, extensive oral lesions where you couldn't really eat or swallow. Those kinds of things is where I think definitely our health authority, APH, or the state would assist in, of course, getting therapies for that. But overall, for the person that just gets these classic small numbers of lesions on your skin, like Dr. Walks said, it's generally mild disease, things clear up in a few weeks, and the mortality is less than 1%. And with that, I will pass it over to Dr. Stefanowicz, who's our Associate Director of Sexual Health Programs at Community Care, for some additional guidance.
Thank you so much, Dr. Mondy. It's a pleasure to be with you all today. Thank you, Dr. Walks, for that introduction as well. My name is Dr. Mike Stefanowicz, and I'm a physician, as Dr. Mondy said, representing Community Care, local nonprofit community health system dedicating to meet the health needs of our local residents here in Austin, Travis County. One of the local oversees the provision of services at the David Powell Clinic. Which is a medical home, for those of you who do not know, that delivers HIV primary care to nearly half of all people living with HIV in Travis County, with an additional focus on the prevention of HIV and sexual infections. Today, I have been invited to speak from the perspective of one of a multitude of different leaders here for a healthcare team that is on the very front lines of this outbreak. At my clinic, at the David Powell Clinic, we have diagnosed and cared for approximately half of the existing cases of monkeypox in Austin, Travis County state. While we do not currently at Community Care offer any type of mass testing for monkeypox at this time, we do offer testing for our established patients at Community Care, in addition to a partnership through Austin Public Health for testing on a case-by-case basis for patients who are not yet established with community providers who may need testing. And I am here with you today as I have been asked to speak to the current 2022 monkeypox outbreak with respect to select communities whom both myself and our team serve on a daily basis, namely the disproportionate impact that monkeypox outbreak has had on gay and bisexual men, both locally, nationally, and on the global scale. So we also know, based on existing data, that many of the monkeypox cases are actually occurring amongst people with established HIV infection globally. And I think now is the time to be both vocal and vigilant about a virus that is circulating in our community locally. So as Dr. Walks has already alluded to, travel to endemic areas where high numbers of monkeypox cases is occurring is not the only risk factor for acquisition of monkeypox locally. And while I just want to echo the sentiments that we are certainly very fortunate that the virus is not deadly in the vast majority of those who become infected and is time limited in most cases and resolves without treatment, but nonetheless, a monkeypox virus can still make people ill, and there is a risk for complications amongst those people who have compromised or weakened immune systems, something that I think is important to speak to today. The monkeypox virus itself can cause a painful rash that persists for multiple weeks, warranting isolation at home. And we've seen multiple instances where patients who see us in clinic complain of fever, swelling of lymph nodes, muscle aches, cough, sore throats, and a myriad of other symptoms. And of course, there is always the risk of transmitting the virus to others and fueling this outbreak even further. Now, in some of the initial people diagnosed with monkeypox in parts of Europe, including Italy and Spain, the vast majority reported intimate skin-to-skin contact amongst same-sex partners. Now, while a significant number of those diagnosed with monkeypox were also living with HIV, the World Health Organization has released similar estimations as well. Preliminary data amongst monkeypox infections over the recent months in people living with HIV do suggest that those with advanced HIV are at high risk of developing complications related to monkeypox, whereas those individuals whose immune systems are better off and more intact and who are maintained on a medication regimen that suppresses their HIV fare much better with a monkeypox infection and do not experience other complications that may warrant treatment or hospitalizations. But just as with many things related to this current outbreak, new data continues to arise week to week. Now, I want to speak to something that I think is very important here. There's been a lot of talk globally and nationally in the spheres of influence of public health and medicine to avoid stigmatizing select groups of people who have been impacted by this outbreak. In this case, I'm speaking about gay and bisexual men or anybody reporting intimate skin-to-skin contact amongst same-sex partners. And I do, as a physician and as a physician, strongly agree with this sentiment as well. I think it is incredibly important to clarify is that monkeypox is absolutely not a disease of the gay community. Rather, it's circulating right now amongst a small subset of this population, but that we know historically that this virus has similarly impacted other very different groups of people in the past. In fact, during a relatively smaller monkeypox outbreak in the US in 2000, gay and bisexual men did not, some healthcare workers as well, who perhaps lacked the appropriate protective equipment and wear, and were in close contact with the virus. So I do want to dispel any notion. This is a condition that perhaps in at all. The message I would like to convey today is actually very clear. Anyone can become potentially infected with the monkeypox virus, created in communities of men who report intimate skin-to-skin contact with male partners, new partners especially. However, we do not want to run the risk of minimizing the current outbreak and letting it go unabated. Because the real risk here is not in this to the community members who perhaps stand to benefit them. I say that not only as one of many healthcare providers leading the charge for equitable access to sexual health care and primary care, but as a gay physician myself. We have the tools to have a sensible and honest dialogue about this outbreak as it currently stands. And I think that the LGBTQ plus community as a whole has proven itself remarkably adept at crafting and amplifying public health messaging to our community members, in part because the community itself has been its most vocal advocate over the years. Often out of sheer necessity. This is HIV itself. I would ask that we remain very intentional with our messaging so as to convey that which is factual and minimize fear, stigma, and misunderstanding, while also ensuring that we inform communities disproportionately affected by this outbreak so that everybody has access to accurate, fact-based information. Because I think at the heart of the matter, health literacy is health empowerment. And so while many questions may remain, and they absolutely do, I do want all of us to recognize our shared responsibility to educate ourselves and our communities. And this is something that we can tangibly do right now. Thank you very much. And with that, I will pass it back to Dr. Desmar-Walkes.
Thank you. And now we will hear from Director Stirrup.
Thank you, Dr. Walkes, and thank you to the medical professionals on this call. So now it's about a call to action. You heard it. Education is key to making informed decisions that will help keep you and your family safe. And that's going to be particularly important while we wait for vaccines to become more widely available. So what does that mean? It means don't have intimate, close contact with a person that you don't know or you're not familiar with their health history. In the same way that you cut open that steak to make sure that it's the temperature that you requested, ask questions of your partner. Know the facts before making a decision to be close or intimate. The virus can be spread, as you heard today, in a variety of ways, sharing items, coming in contact with sores, that could have contaminated clothes, bed linens, cups, cigarettes, eating utensils. I think one of the most important things that we learned from the COVID-19 pandemic is that we need to inform ourselves with information. And if we are experiencing any symptoms at all, we need to reach out to our medical care provider to ask questions and get tested. And with that, I turn it back over to William. Thank you.
Thank you, Director Stirrup. Now we will open it up to our poll reporter, Grace Reeder from KXAN, who will ask questions on behalf of the media.
Hi, everyone. As always, thank you so much for your time and for taking our questions. The first question is from us at KXAN. Why is Austin Public Health putting the emphasis on monkeypox education that it is, even though this is a small number of people infected and is overwhelmingly not fatal?
We've learned from our experience with the COVID-19 pandemic that arming the community with education about what's going on in the public health arena is beneficial to addressing those problems, because then people can make informed decisions about how to protect themselves and thereby protect our community.
I'll just add briefly, as a public health department, we would be doing our community a disservice if we did not take steps to be true to our mission, which is to prevent disease, promote health, and to protect. And so any information that we can have before we get to a crisis stage so that our community is prepared, that's our job.
The next question is from CBS Austin. When the COVID pandemic began, there was a lot of talk about groups being higher risk than others. Does monkeypox have any higher risk age groups?
The CDC reports that children who are under the age of 8 are more susceptible to severe disease. And I pass this question on to Dr. Mondy as well.
Yes, I think I touched on that pretty well in my opening statements. But yes, we think that children under 8 and I know that there's some data out of Africa, but that included the more virulent strain, that in one study there was even up to, when you combined all the strains, higher than a 10% mortality. So I think we worry about our young children. Pregnant women, again, it can spread to the fetus and cause miscarriage. And then immunocompromised people, I think we've learned from COVID that there are a lot of people taking medications that cause immunocompromise, people that take immune modulators, high-dose steroids, chemotherapy, and like Dr. Stefanowicz said, people that have perhaps, very advanced HIV. So that could be a large number. And then finally, people that get extensive infection, if you accidentally auto-inoculate yourself or get it in multiple sites, that could lead to potentially secondary infection. It could lead to more organ infection. Rarely it can cause a sepsis-like picture, a pneumonia, encephalitis, things that severe eye infection that could cause hospitalization. So those are the main areas.
The next question is from KUT. What is the vaccine situation in Austin? Folks in cities like New York City have said that they've had difficulty signing up for vaccines. They're wondering if APH has a plan to scale up vaccination appointments similar to COVID, and if so, would there be a similar sign-up system?
We currently are vaccinating people who are identified as contacts, close contacts of people that have been confirmed to have monkeypox. As we receive more vaccine supply, we have plans in place to scale up our operations.
The next question is from the Austin American-Statesman. Is Austin Public Health starting to vaccinate people, and how are you deciding who to vaccinate?
We're following the guidance of the Department of State Health Services and the CDC, and using the eligibility criteria based on risk exposure. So those individuals who've had a high risk exposure to someone who is positive for monkeypox are being prioritized for vaccine. And then we follow that guidance throughout.
The next question from Fox 7. Do you anticipate monkeypox being as widespread as COVID? Can someone be asymptomatic, and are the confirmed cases hospitalized?
Hospitalization of our monkeypox cases based upon the severity of disease. And at this point, we are fortunate to report that we do not have any confirmed cases in hospital. The actual spread of this disease will really depend largely on the response of the community to the guidance that we're giving today and have given, which is to protect ourselves and to limit the spread of this disease by following the infection control measures like avoiding contact, skin-to-skin contact, sexual contact with people who are positive for monkeypox, hand washing, and then just the sanitization of hard surfaces and cleaning linens and upholstery appropriately if somebody's been using those things who is positive for monkeypox.
And I'll just add to that it's important that people with monkeypox talk to their provider. The CDC has handouts, but there is a lot of personal responsibility. You can be contagious until your lesions are completely scabbed, crusted, they flake off, and you have new skin growth. So that could be 3 to 4 weeks. And in looking at other data like the WHO, because it's not fully determined about the sexual transmission piece, they recommend that people use condoms for additional 12 weeks after that. So that requires significant, personal responsibility. But I think our community can do that.
I do want to echo what Drs. Mondy and Walks had just mentioned with respect to tangibly what people in the community can do right now, because we do know that as Dr. Walks had mentioned just now, that the vaccine availability is limited in quantity at this time. There are future plans, and I'll defer to Austin Public Health on that for further discussion. But people in the community want to know, both on the service provider side and for community members, what they can do right now to help mitigate or reduce their risk. And as I had said in my opening remarks, health literacy is health empowerment. Seeking verifiable, trusted resources for education, visiting the CDC and the WHO's websites, I think are great resources real time. Social media platforms happen to be very big platforms by which we share and amplify information together as a society now. And I think it's incumbent upon all of us, per Dr. Mondy, what she had just said, part of our responsibility as citizens is to if we are spreading information on social media, recommend mimic that with medical providers would see
Mike, we're
Doctor.
having difficulty with your audio and your videos.
I'll move on to the next question, and if he gets that figured out, we can come back to it. And Dr. Walks, you were just answering some of this question from Co-op Radio, but they are asking about the virus on surfaces, and they additionally ask how long the virus is contractable from an object.
The CDC has put out a document that states that for 15 days after someone who's had monkeypox has not occupied a premises, that we can still find live virus. So it's important that we utilize EPA-approved cleaning products and follow the instructions for how to use those and allow those chemicals to dry. And then, consider steam cleaning, upholstery when necessary, and making sure that when we're washing clothing and bed linens and whatnot, that we're handling those wearing gloves and mask and eye protection, because, as I said, the fluids, body fluids, and scabs have live virus and can potentially infect those that are handling those objects.
The next question is from Univision. Does APH have enough toolkits needed to test for monkeypox in case demand for testing does go up?
We do have enough supplies for testing. We are collecting the samples that are submitted by providers of patients that they're seeing. And then those samples are actually being run by the Department of State Health Services laboratory. We do have one lab that is a commercial lab that's doing testing as of yesterday. And we're anticipating that more commercial labs will be coming online in the coming weeks, which will help with the time factor and of the increased numbers of samples that we'll be receiving.
The next question is from KView. What was the criteria in order for monkeypox to be considered as community spread in Austin?
We started to see people who had confirmed cases of monkeypox in our community that were related to them having contact with someone who had no history of travel. And that signaled the beginning of spread in our community that can happen between people regardless of what socioeconomic or whatever group they come from, demographic group they're from. So it's now incumbent upon us as a community to take precautions at all demographic levels, because it is now in our community and it is possible for spread to occur.
We're now going on to the second round of questions. So this one is again from us here at KXAN. Can you give us a good frame of reference for how contagious monkeypox has been here locally?
Could you repeat that question, please?
Sure. So just asking, can you give us a frame of reference for how contagious monkeypox has been, for example, compared to perhaps other diseases? I think people are having a difficult time understanding really how contagious this might be.
So we look at a reproduction number, and that has been estimated to be somewhere in the neighborhood of 2, which looks at how many people one person will infect at a time. And that typically the number has been calculated at 2. But as the science evolves and as we look at what the situation is here in our communities and in our nation, that may change. So it is very contagious. It's spread by contact with respiratory droplets. It's also spread by contact with the fluids that are associated with the rash that's on the skin. And it is also something that you can spread by having the scabs that still have virus that's viable in them, contacting those who are not infected. So it is contagious, and it is important that people protect themselves by washing hands, wearing a mask if they're going to be in close quarters, and avoiding skin-to-skin contact with those that have monkeypox.
The next question from CBS Austin. With Austin ISD returning to class 1 month from tomorrow, are you all working with schools on monkeypox protocols? And what should parents have their children do to stay safe in a school setting?
It's going to be important for the adults that are caring for children to protect themselves, and so that their children don't become infected. And we will be and have been working with schools on an ongoing basis with infection control measures in school settings, and we'll continue to do that.
The next question is from KUT. The CDC announced this week that it's expanding its partnerships with commercial labs to test for monkeypox. Do you expect that to result in an increase in testing capacity in Austin? And is there a possibility for larger scale testing sites, or would it be on the provider level?
The introduction of commercial labs will definitely help improve our testing capacity. And these tests will be performed on a provider level because of the nature of this disease. It will require an evaluation by a medical provider.
The next question is from the Austin American-Statesman. Have there been pockets of infection? What are the characteristics of those pockets? Who are you seeing have been most at risk in Travis County?
We're not seeing clusters of infection. We are seeing community wide infection that's happening in different parts of our community. And what was the second part of that question? What was the second part of your question?
The second part is, who are you seeing having been most at risk here in Travis County so far?
It's predominantly been seen in the 20 to 49-year-old age group. And so far it's been males.
The next question from Fox 7, could people with skin conditions like eczema be affected more severely?
Yes, that's true. And I'll pass that on to Dr. Mondy as well.
Yes, that's a good question. People that do have significant ongoing skin conditions are also considered at higher risk. I think they already have skin inflammation, and that makes it worse. And also it could predispose with more skin involvement and a higher risk of than secondary infection. Yes.
This next question is from the Co-op Radio. They say, you suggest typical NPIs are effective to reduce contagion and that we should focus on hand hygiene. Do sanitary wipes disinfect impacted surfaces and objects? Does normal laundry cleaning disinfect objects?
You need to check what your wipes have and check the EPA list for those ingredients that are effective in killing virus. As far as laundry goes, the CDC guidance for cleaning laundry is to use regular laundry detergent in a washing machine.
And the final question is from Univision. They ask, what about people who have already had chickenpox before, and they probably mean smallpox? Are they at a higher risk of getting sick with this outbreak?
Do they mean chickenpox? Yeah. Or do they mean small? Yeah. People haven't had smallpox. That was like eradicated in the early 70s. There's a lot of confusion, but chickenpox is a member of the herpes virus family. And the orthopox is not in that. That's a completely different family. It includes smallpox, called variola, vaccinia, which is a type of related virus that they use to make the vaccine, and then monkeypox. They said that people that have had a prior smallpox vaccine could have immunity, but if it was given so long ago, they could have waning immunity. But if you're related to the vaccination of smallpox, that does come up, and it's interesting because my understanding is a lot of people in the military have been vaccinated for smallpox. And then I would say that if that was not that long ago, that would probably protect them.
And that's the final question. Thank you all so much.
Thank you again, Grace, reader from KXAN, for being our poll reporter today. Now I'm going to pass it along to Dr. Walks for final thoughts.
I want to thank my colleagues for joining us today and thank Director Stirrup for your wisdom and call to arms and call to action. We're hoping that our community has had a chance to digest the information that you've heard today, and that you will take this information and help us all work together to care for those that are in community who are dealing with monkeypox at this point, and help them through that, understand that as supply of vaccine becomes more available, that we will continue our efforts and expand to our capacity to vaccinate. And also know that we are here, all of us, all of the healthcare providers on this call and colleagues throughout the city, to help those that identify themselves as having symptoms or and present themselves, that we're ready and able to treat them. And that if we work together on this with taking those infection control measures that we've talked about today, that this can be controlled and that we can effectively bring a stop to it. So I thank you for your time and attention, and thank you.
All right. I want to say thank you to Dr. Walks, Director Adrian Stirrup, Dr. Kristin Mondy with Dell Medical at the University of Texas at Austin, and Dr. Mike Stefanowicz with Community Care. Thank you for joining us today. And of course, Grace Reeder with KXAN for being our poll reporter today. We hope you all have a wonderful Thursday. Thanks.